Julie, you did good. Keep going.
Hi, my name is Julie Kirk. I'm a professor in the Department of Family and Community Medicine. And my colleague, Dr. John Spangler, who's also a professor in the Department of Family Medicine at Wake Forest School of Medicine, will be presenting information on the STOP Act of North Carolina today. Neither of us have any relevant financial relationships with commercial interests pertaining to this content of the presentation today, and we have absolutely no conflicts to report. The objectives of our presentation today will include describing the components of the STOP Act, and that stands for Strengthen Opioid Misuse Prevention Act. And we'll be emphasizing some of the epidemiology in the state of North Carolina of opioid abuse and harm reduction provisions. We'll also review a little bit about the North Carolina Controlled Substance Reporting System. We'll discuss a few case scenarios with an emphasis on opioid avoidance that are intertwined with the STOP Act provisions, and then we'll identify situations of patient issues with harm reduction strategies. So first of all, let's talk about the problem. We have some of the top cities in the state of North Carolina from the Cast Lights report, and it comes from anonymous health data of nearly 1 million people who employer-based health insurance to map the 25 worst cities in the U.S. for opioid abuse. We rank number 1 in Wilmington, North Carolina at 11.6% for opioid abuse, followed by Hickory, Jacksonville, and Fayetteville. When we actually look at the map of the opioid abusers, you can see that we are not alone in North Carolina, and it gives the distribution of the problem. Some more compelling data that's very recent, as of 4/17/2018, is the North Carolina Emergency Department visits for opioid overdose. And as you look at this graph, you can appreciate that looking at the full year versus by month, if we just look at opioid overdose ED visits for March 2018, you're ranking several visits per month compared to last year. So instead of the problem de-escalating, we are still escalating in the state of North Carolina with most recent data. And then if you look at the actual graph of the ED visits compared over 2018 to 2017, we're on the trajectory of rising. So have an appreciation of the total numbers and percentages here from this graph. Also, it's an equal opportunity employer for opioid abuse. You can see that it spans a wide range of age groups with a problem at all age groups, but a concentration, if you can look in the middle of the bottom left graph, that ages 25 to 34, 20, up to 50 is probably our highest percentage, and tends to be a higher distribution in our white versus black populations. But you can see it affects everybody, and this gives you a little bit more of the demographic information related to opioid overdose ED visits by county, also in the state of North Carolina. So there's been some focus areas for the North Carolina Opioid Action Plan. We need to create a coordinated infrastructure that hopefully reduces oversupply of prescription opioids. We also know that there's a overlay of diversion of other illicit drugs, fentanyl factories making in people's homes, and so there's gateway drugs that a lot of co-administration of illicit drugs with opioids. So we have to reduce diversion of flow of those drugs and increase community awareness and prevention. This has been a big emphasis, and Project Lazarus in Wilkesboro, North Carolina is a prime example of a community project that has worked and decreased their numbers in that area. We need to make naloxone widely available, and this has been directly linked with improving surviving rates and enabling pharmacists in my profession to be able to administer naloxone, as well as first responders and others. We need to expand treatment and recovery-oriented systems of care, and then measure our impact and keep revising strategies to do what works. So again, the number of unintended opioid-related deaths, if we do nothing, will continue to rise. And we want to project our goal of a 20% reduction from expected. And that's what the graph depicts on the left side here, that's our goal in North Carolina. And I think it's accomplishable. So what is the NCCSRS? It's the North Carolina Controlled Substance Reporting System. It's a statewide reporting system that was established as a law to improve the state's ability to identify people who abuse and misuse prescription drugs classified in Schedules 2 through 5 controlled substances. It's also meant to assist clinicians in identifying and referring for treatment plans. And the North Carolina Commission, the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services makes rules and manages the program. Now we know it is an extra step in clinic to have to check this reporting system, but it is critical to, even in the most honest-looking patient, check the system before and periodically as you develop relationships, but at every juncture you can, when you're prescribing a opioid, you need to check the system. So you enroll the system through going to the internet browser, putting in this address I put on the slide, and we have all of our residents in our program register. All physicians need to be registered. Anybody prescribing controlled substances need to be registered in this program. So let's move on to the STOP Act. This new law was aimed at curbing misuse and abuse of opioids in North Carolina. It was passed unanimously by both houses of the General Assembly on June 28, 2017. Signed by Governor Roy Cooper on June 29th, and is now being focused in our clinics for upholding this new law. Targeted controlled substances under the Act, Schedule 2 and Schedule 3 opioids. So I've listed out codeine, morphine, oxycodone, hydrocodone, fentanyl, methadone. It does not include stimulants such as Ritalin and other medications to treat ADHD. So methylphenidate is not included in that. The first provider provision I'd like to talk about today is the actual time frame of prescribing. Prescriptions following a surgical procedure are limited to 7 days or less, okay? If a follow-up prescription is necessary, it needs reassessment by the provider. Now, this does not apply to hospital situations, nursing home residents, hospice facilities, or residential care facility. If you've got somebody with cancer in a hospice situation, it does not apply to them. Dispensers are not liable for dispensing a prescription that violates the limit. So, effective January 1st, there's quantity limits that will be required on initial prescriptions for targeted Schedule 2 and 3 opioids. A 5-day supply for acute pain, any type of pain. I come in, I've hurt my back, I fell on the ice, 5 days. For post-op pain, 7 days or less. No refills, and again, to reemphasize, additional fills must be authorized pending the determination of need by the provider. So our first case is a 67-year-old established patient who had a total knee replacement 3 weeks ago. His prescription bottle shows he was given 7 days of oxycodone for pain, 10 milligrams every 4 to 6 hours, number 42. He states his post-op pain is still bad. It's about a 9 out of 10, and he just can't walk well. He called his orthopedist, who said, "You should call your provider. Your knee should be healed by now." He wants you to refill his oxycodone. Nothing else works. What should you do? I'd like you to take a second to think about what you would do, and I'm going to hand over the talk to my esteemed colleague, Dr. John Spangler, who also works in a Suboxone clinic here in our psychiatry department at Wake Forest School of Medicine. Dr. Spangler?
Okay, well, so kind of an interesting case. We see a lot of these cases all the time. Just had a patient a couple of weeks ago, the exact same scenario, which is sort of what I developed here. So what should you do in a patient that comes in, post-op pain, has not gotten better after surgery, and patient's orthopedist wants you to sort of take care of this? So, I mean, first of all, I just want to say there are many ways to approach a case like this, but bottom line is to inquire about any drug-seeking behavior. And you should look at the North Carolina Controlled Substances Reporting System to see if this patient has gotten refills elsewhere, and you can also see if he was taking it before he had surgery as well. So you just get a sense of his history of controlled substance use. And I would ask also about patterns of use in the past of opioids, but also the use of any other substances. Cocaine, heroin, obviously, even marijuana or alcohol use, because co-use of these other illicit substances can actually obviously complicate taking opioids for pain. And counsel the patient as appropriate. I would personally try a fairly strong NSAID, like meloxicam, for example, if the patient can take it, not contraindicated like for liver issues or kidney issues. And I would also send this patient for physical therapy. But if the pain persists, or if the drug-seeking behavior persists, at that point I probably would refer to the pain clinic or back to the orthopedist. Actually probably call the orthopedist and say, these are the issues we're still struggling with, what are your recommendations? If you see on the controlled substance reporting system that the patient's been getting opioids from providers all over the place, then it's probably reasonable at that point to send the patient to an addiction treatment facility. For example, a buprenorphine or Suboxone clinic for medication-assisted therapy. So, but the one thing to really keep in mind, as we mentioned earlier, is that for post-op pain, the STOP Act requires that you prescribe only 7 days. Not an open-ended 21-day, 1 month supply. There can be this tendency to want to give them a lot so that they won't call you back. And we'll sort of, have to cut down on the telephone calls and the negotiation that goes along with that. But the STOP Act is trying to stop that and requires that for an initial prescription for post-op pain, you give 7 days. But the law does allow you to continue the oxycodone. You can do that on your own choice. But you should obviously redetermine the patient's need for this. And again, in this particular case, I would probably go with a non-steroidal anti-inflammatory, plus some physical therapy, and obviously consult again with the orthopedist. However, some patients do require refills on their opioids, and we should be open to that, given that everything else we've talked about is not concerning. So, what are the provisions for prescribers of the STOP Act? The first one is to check the North Carolina Controlled Substance Reporting System prior to prescribing any controlled substances for the first time, and then also every 90 days if prescription continues. So this is something we should be doing with our patients we already have on chronic opioids for their chronic pain. You must review information in the reporting system from today back to the past 12 months and document that you've reviewed that in the medical record. The system knows whether you come in and reviewed or not, and so documentation in the note also reinforces what the system has recorded, and also, by the way, indicates whether you looked at it or not if you document it in your chart. It's not required for controlled substance use in health care settings like your office, for example, if you have to give a shot of morphine. It's not required in hospitals or nursing homes, dialysis facilities, or other long-term residential care facilities. Now, this is what I mentioned earlier. The Department of Health and Human Services will periodically audit the North Carolina Controlled Substance Reporting System for what you have done. And again, if you've documented that you looked at the system and looked at the system for the past 12 months, you'll get credit for that. But the Department of Health and Human Services has the authority to report violations of not looking back to your respective licensing board. And the board can suspend or even revoke your license based on violations of the STOP Act. So, physician assistants and nurse practitioners treating patient in a pain clinic setting. Now, this is a pain clinic setting. This is not a primary care setting. But in a pain clinic setting, they're required to personally consult with their supervising physician prior to prescribing one of these controlled substances if the use is going to exceed 30 days. Now again, the PA or other provider can give a 7-day or a 5-day prescription, but prescriptions that go beyond 30 days, the advanced practice provider must consult his or her supervising physician. And during that consultation, should determine together whether the prescription is medically appropriate. And the APP should reconsult with his or her physician every 90 days if the prescription is to continue. And again, now this is a pain clinic setting. So, just to repeat, effective July in 2017, PAs and NPs working in pain clinics must consult supervising physicians before prescribing opioid prescriptions that exceed 30 days, and every 90 days they need to reconsult. And of course document that in the chart. And this also includes looking at the North Carolina Controlled Substance System regularly. So for chronic pain in other clinics, like your primary care clinic or other non-pain care clinics, the STOP Act does not limit the amount of opioids that may be prescribed to a chronic pain patient, a patient with chronic pain. And the North Carolina Medical Board recognizes that we all have patients like this. And so they did put out this statement back in 2017. So let's look at another case. The physician assistant working with you in your family medicine clinic has a patient with recurrent back pain for whom she thinks opiates are appropriate for today. And she states, I think this is going to be a long-term problem. How should I write his prescription? And of course, you know, there's that dialogue. How should we do this together? So what should be your response to your physician assistant? So the first thing to do, if your physician assistant hasn't already done that, is to check the North Carolina Controlled Substance Reporting System. I would be reluctant to start opioids on a patient with recurrence of chronic pain or musculoskeletal pain in particular, because NSAIDs and muscle relaxers probably are a better choice, obviously long-term. And there's other alternatives, for example, physical therapy. But you can have that discussion about, you know, whether an opioid would be appropriate or not. And the law does allow your physician assistant in primary care or non-pain clinic settings to prescribe 5 days of opioids depending on your agreement with your APP. And this can be used in an acute exacerbation of chronic pain. For example, this patient has, you know, recurrent back pain periodically. You could look at this as an acute episode of a chronic problem, or some people might look at this as a chronic episode. I would tend to say this is an acute exacerbation of a chronic episode. I would not prescribe personally opioids here, I would rather defer to NSAIDs. But some people might, and if you do use opioids in this situation, you again are limited to a 5-day prescription because this is a new prescription for this patient of an acute exacerbation. Now, the STOP Act does not limit the amount of opioids that may be prescribed to a chronic pain patient. Again, the North Carolina Medical Board said this, and it's really important to mention that, again, we all have these chronic pain patients on long-term opioids, and so you sort of have to, as this case illustrates, determine is it an acute prescription for an exacerbation of a chronic problem, or is it a chronic problem? And that takes some clinical judgment. But as long as you're going through the steps the STOP Act mandates, and you're documenting those steps in the chart, you'll be good. There are some exceptions to this. Again, controlled substances dispensed by a practitioner to an ultimate end user. Well, that just means you have a patient in the clinic that needs a shot of morphine for some acute pain or some procedure that you're about to do. And that would be in your clinic, would not necessarily be in a pain clinic. Also controlled substances, as we mentioned, given in hospitals, nursing homes, hospice, dialysis, etc. The prescription requirements, electronic prescription requirements don't apply. And prescriptions given by veterinarians. If the practitioner provider develops technological issues such as electrical failure, just document that in the medical record. That's what's happened, and that's why you could not prescribe electronically. So the dispenser, now this is the pharmacist or the analogous person in your particular situation. So the pharmacy needs to register also for the controlled substance reporting system. And it needs to be used in any dispenser of controlled substances schedules 2, 3, and 4. The pharmacist is required to look at the controlled substance reporting system if they have suspicion that the patient is displaying drug-seeking behavior. Pharmacies are required to report to the North Carolina Controlled Substance Reporting System by the close of business day. So, and sometimes it takes a little bit, in my experience has been, it takes a little bit of a while for yesterday's or 2 or 3 days ago prescription to be incorporated. The previous law allowed up to 30 days. And if the pharmacy does not do that, there will be monetary penalties. Let's switch gears a little bit to Medicaid. Medicaid has revised their policies to better align with CDC's policies, and Medicaid developed a North Carolina Opioid Action Plan aimed obviously at reducing the oversupply and overprescription of opioids, which a good portion of those end up being diverted for misuse. So for Medicaid, as I mentioned earlier, prior approval is required for starting any opioid, and that includes tramadol. And the prior approval also will require you to start, to determine prior approval if you have more than 120 morphine milligram equivalents per day. If your supply is greater than 14 day supply of any opioid, and if it's a non-preferred opioid product that North Carolina Medicaid does not have on a preferred drug list. So you have to consult that to see. There is also the North Carolina Tracks portal, which allows Medicaid providers to actually log in, submit prior approval requests through either the portal or by fax. And again, new opioid analgesic authorization forms are required to be submitted through the Tracks portal. Looking at, I won't go through this whole chart, but it does give you an idea of opioid prior approval through Medicaid, when a prior approval is required and when it's not required, any exemptions and length that the prior approval lasts. You can get all of this information from any of these resources. Switching gears now to talk about harm reduction procedures. The North Carolina has amended the Good Samaritan Law to allow community distribution of naloxone by organizations like the fire department or police department. And they can have a standing order to distribute naloxone. The standing order may be written by a practitioner to any government or non-governmental organization, including the local health department, law enforcement, because naloxone, as we know, is scientifically proven to mitigate health risks associated with substance overdose, particularly opioid overdose. The organization is required to have basic instructions and information on how to give naloxone, and the organizations and its agents are given immunity from for any distribution or applications that give, which of course falls under the Good Samaritan Law. Well, thinking about workflow strategies, it is true that consulting the North Carolina Controlled Substance Reporting System is another step. There are several clicks to get into it, but it's the law, and so we should do that. However, we can also delegate non-physician or non-APP resources like your nurse to actually access the Controlled Substance Reporting System and look at the patient's background, print it out for you before your visit. If you're with a patient, or as your nurse rooms the patient, you can ask the patient the screening questions, brief intervention, provision, and refer for treatment screening tools, also known as ESPER. So you should be consistent. You should ensure that your patient flow and rooming and prescribing situations follow a consistent pattern that can improve patient safety. In doing this, though, hopefully we can destigmatize the label of opioid misuse. And there is some more safety community issue information listed at this URL. So let's stop for a minute and just think about red flags. Patients coming to your clinic requesting opioids. Now, we all know, many of us know the red flags, but let's just think about that. What are possible indications of drug-seeking behavior? So some examples. The prescriber or the patient is from outside the dispenser's geographic area. We live in Northwest North Carolina. We get patients from West Virginia, Tennessee, who come to us, even Virginia, who come to us seeking opioids. I don't have access to their state reporting system, so it's a little dicey. And I usually do not prescribe in that situation. A patient pays cash, they don't want an email, electronic trail, if they have insurance. Their insurance should cover this, but if they pay cash, it's sort of a red flag. If they are continually requesting early refills, this is a big one, we all see this in clinical law. Or if you determine or find out through the Controlled Substance Reporting System that they're getting the controlled substance from multiple providers. And one thing I've also encountered is that they may not be getting their controlled substances from multiple providers, but they may be getting it from multiple different pharmacies. And so they may get their opioid prescription at pharmacy A, they may get their Soma or Valium prescription at pharmacy B, etc. And that way, they don't trigger a red flag in the pharmacist's mind that this patient is getting a lot of opioids and at the same time getting a lot of benzodiazepines. This goes back to our responsibility. We should not be prescribing multiple controlled substances that put our patients in harm's way. The dispenser should is required to actually contact the prescriber to verify if these prescriptions are medically appropriate and let the provider know any concerns. And failure to conduct the review does not constitute negligence on the pharmacy's point. So hopefully you learned something about controlled substance use in North Carolina and the STOP Act. And we will be having some send in the questions and be able to answer you at a point not too long from now based on any questions you have regarding our presentation. So thanks so much for attending.